Just quickly say thank you to everybody for joining this morning, and thanks to Dr. Lichtenberg and his team who have put together this interesting live case demonstration. And I hand the floor over to Dr. Lichtenberg, who will take you through the initial angiograms and talk to you about this patient and what he intends to do. So thanks very much, Dr. Lichtenberg.
Thank you very much, Warren. Good morning. Good morning from Arnsberg. It's a pleasure to welcome you here in Arnsberg, and thank you very much for supporting us here doing this live case, which I will show you in a second. Turns out to be a BTK case. Briefly, let me introduce you our team here. We have Annabelle, we have Katharina, we have Jason. So a lot of people sitting out there, actually, this morning. And it's a full sedation case in a very old patient. I will briefly introduce him, this case to you. He's 84 years old, is a Rutherford 5 patient with a known peripheral artery disease for many years. We treated him a couple of times on the left side. Now he came with the right side, D1 necrosis on the right side. Yeah, and we already did so that we are not wasting time and antegrade access in this patient based on Doppler duplex. There was no inflow disease from the iliacs as well. The femoral popliteal artery here, as you could see here, this is already in 6 French antegrade access. The main problem in this Rutherford 5 patient is this more or less complex P3 occlusion, and then we definitely see a 3-vessel outflow there. But this 3-vessel outflow itself is a little bit diseased, especially in the main feeding arteries, the anterotip artery. There might be some stenosis here. Posterior tip is not too bad, but because of the P3 occlusion, definitely slow flow, but you can see that there is a 3-vessel run-in. So I think we try to open the P3, of course, and then check on the inflow to the foot itself, the anterotip artery. Maybe it's the one of the most important in this particular case here, but we'll see later on. So our approach would be now to analyze what kind of occlusion we have here in P3. This is where we are at the moment, and have already an 014 wire here in this. And this is a case, again, show you the angio, where I definitely want to know what kind of occlusion morphology is it. Is it more chronic disease? Is it maybe a thrombus? However, um, we don't know so far. And this is, I think we need to find out, because based on this morphology analysis, we definitely should decide then on our specific therapy, and hopefully not having any embolization in the foot if this turns out to be a more softer or even a thrombus plaque burden. And therefore, our next step will be to try to get a wire through this disease here, uh, which is in the place. And while I'm doing this, maybe for the audience, any questions, remarks to this case? And then we'll try to navigate here through this, whatever this is, pressure or soft occlusion, I don't know. Actually, it works very well. Yeah, so please, if there are any questions, remarks, please go for it. Warren will take these question remarks, and then we can discuss on this individual questions and comments.
So the first question is, which wire are you using, please, Dr. Lichtenberg?
Yeah, so this is actually an 014 wire, Advantage 14 wire from Terumo, hydrophilic coated wire, and it went super easy through this P3 segment. So there's a high suspicion that this is a more softer thing here, maybe. So maybe organized stuff and some thrombus on it. But to evaluate this more and learn about the morphology and not just rely on angiography, we decided to do an IVUS. And this is what Katharina is now doing. She's getting me an 014 wire based IVUS on the wire, and we are bringing the IVUS in Italy. Please, IVUS. Yeah, thank you. So now you see IVUS. Unfortunately, we have Kimberly Peppers out there. She will support us with IVUS here. Good morning, Kimberly, again. So I'm still in the sheath right now with the catheter. So I'm now in the distal SFA. Show you fluoro where we are. So I'm right out of the sheath now, advancing the catheter. As you could see here, ring is down. We see some sclerosis of the intimas, but definitely no disease as just seen on angio. But now it's getting, I think, more interesting. What is about the popliteal segment, and especially what is it about this softer material in P3? Yeah. And I will now slowly advance, give you an interim angio fluoro view. There's some plaque burden here between 12 and 6 on the clock, but this is more chronic. Now you see some flow phenomenons here. This is because of the slow flow. You can see actually an echogenic echo here from the blood itself because it's stuck here. Now I'm advancing it. And now we can clearly see it here. This occlusion starts.
Is it possible just to make the IVUS image a little bit bigger on the screen for we're just losing a little bit of that's yeah, that was a little bit better. Yeah, that's brilliant. Thank you.
Yeah. Okay. Yeah. So, okay. And here's a full occlusion. Yeah.
Yeah.
Doesn't look too soft, eh?
Yeah, it's a interim thing, I would say. Yeah.
Yeah.
Maybe some
Yeah.
fresh in between, but you're right. There are a lot of speckles in there.
Yeah.
Echogenic speckles. Yeah. 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 This is still P3, and now we come close to anterotip artery offspring here.
Vessel also looks quite large, no? 4 or 5.
Absolutely. Yeah,
Yeah.
absolutely. Yeah. So still occluded. We are nearly in the anterotip artery here. Occluded. And now we are coming back into a true lumen here. Some disease here, slow flow phenomenon, some calcification at 3 o'clock to 6 o'clock, but here's definitely flow. Okay, so what did we learn? Actually, Angio just showed us there's an occlusion, of course. Angio can't tell us about the morphology of this occlusion. IVUS now gave us the information that there is a mix morphology of maybe soft plaque plus maybe interim thrombus on it. So the question is how to attack this now. 1,8. And this is the question. And if there are any suggestions from the audience, please forward to me. Otherwise, I tell you in a minute what we are planning to do. So we can go back to Cam 1 and Cam 2. Thank you. There's really one option I do not accept is call a vascular surgeon. This, unfortunately, I do not accept.
Surprise.
If so, we definitely need to do that from an endovascular approach. So my idea is, as we learned that this is a mixed morphology, let's try an Archimedes screw aspiration, a thrombectomy, arterial thrombectomy with the Phoenix 1.8 system. So because of this mixed plaque structure, I think the Phoenix 1.8 is a good idea. It can remove the organized material. Because of the Archimedes screw principle, we hopefully don't have any embolization. So I think the Phoenix will do his job, and we are in the middle of preparation. Katharina is preparing the device. We will see it in a second here in the center. So we attach the motor to, ja, wir wechseln mal Ballon bitte. We attach the motor to Ballon kurz. Attach the motor to the catheter itself. While this is done, we need to change the wire, of course, because this is still an hydrophilic coated wire, an O14 hydrophilic coated wire, which is definitely not the best option for an acoustic screw principal system for rotation thrombectomy system, arterial thrombectomy system. I will change here now to a non-hydrophilic coated wire, bring it in, and then we can exchange the wires using a balloon here, just as an exchange catheter, and then go with the Phoenix catheter. Yeah, for this purpose, I bring in this catheter very deep into the antertip artery, place the wire then there, and then we are good to go, hopefully. Okay, awesome.
So, Dr. Lichtenberger, one of the comments was about the use of a filter. So one of the participants said filter first and then atherectomy.
Yeah, that's definitely a very good question. The question is where to place the filter. We have 3 vessels. So I'm not aware that there's a 3-vessel filter system right now. A specific design filter for these kinds of circumstances is on the way, actually, from a startup company. We can maybe discuss the next time about this, as we are one of the centers here to test this. But here, where to protect? Yeah, is it the antertip? Is it the posterior tip? I think it doesn't make sense to place the filter above the antertip artery, because there is still this occlusion. So therefore, I think with an Phoenix thrombectomy or atherothrombectomy system, atherectomy system, we will not have so much issues with peripheral embolization. There might be a kind of slow flow afterwards, which might be also a little bit of vasospasm, which we quite often see in these scenarios. But I think we can control the risk here with this Phoenix system. So let's advance it. Again, it's the 1.8 system. There's a 1.5, 2.2, and 2.4 system as well on the market. I think it's a compromise here. If we want to dive later on also into the tibial arteries, we can still use it. Here we go. So we start a little bit above the occlusion, right here. Yeah. Katerina is fixating the wire at the back end of the catheter. Just show you the catheter. Wir können die ein bisschen, dass wir das Phoenix immer eingestellt kriegen, bitte. Ja. So here we go. Here's the activation knob. And then we starting the helicopter. So you already hear maybe some change of the noise of the system. What we are checking is that blood is coming out here from the acoustic screw. You can see it here. Yeah. So we typically do not use any collection bag. We just leave it open or yeah, put a finger on that. Really no 500cc collection bag. So what I definitely do here is I will do a very slow advancement of the system. So that the acoustic screw with its negative pressure can really capture and clear this material. In between, I definitely hear a difference of the speed of the acoustic screw. You probably won't hear it, but this is always a sign that the system is working on more organized plaques or morphologies. Also here. So again, it's super important to do it very slowly. So we're still aspirating blood. There's still blood coming out here. You could see my first finger. Now around the curve into the true lumen. So I now do the same very slowly on the way back just to capture and clear a little bit more here. Nitro ein bisschen vorlaufen. Nitro. Nitro. So let's pause here for a second. Let's just see what we have achieved already here. Or if we need a second or third approach. Oh yeah, okay. We already have some antegrade flow here. Yeah. See, TP trunk is also affected. Yeah. So we are clearing here definitely the lumen, but I think it's important to do a second or even a third run later. And I think we start with a second approach here. So I will concentrate a little bit more here in the P3, just above the antitip of spring. And what we probably should do is we should also get the wire into the TP trunk and work also there a little bit. So I think I will do this right now. I pull back the wire and try to navigate with this non-hydrophilic wire into the TP trunk. I don't know if I can really make it with a non-hydrophilic wire, which is not so easy. Um, I'm somewhere. Here we go. This is the pineal, but this is okay. I think get the wire straight down. So the Phoenix is also a good support catheter, I must say. Huh? Can use it also for this purpose. Okay, so park the wire here and then let's activate it here for the TP. Then we have also a little bit more chance to clear from a different angulation also the P3 into the TP trunk. So the battery usually lasts for a minimum of 20 minutes. I never came to this point where the battery became low, but just to let you know this, so this battery-driven motor unit has a minimum of 20 minutes run time.
I think very few people have managed to exceed the battery life with the Phoenix device. in
No?
normal
Okay.
space. Yeah, yeah.
Yeah, 40 minutes, 20 to 40 minutes is a long time.
Yeah.
I think we've run up to like 50 minutes and still had juice left. So there's a big
50,
margin.
50
Yeah,
even.
50.
Okay.
Yeah.
Okay. So we
Wow,
are
nice.
making good progress here. No? Yeah, of course, there's still a lot of material in there, um, because of this very soft nature of this plug here. I think we do one more, two more here, and then we should decide what is the next step. Because the last thing we want to have is significant peripheral embolization in the big tubules. So is just a POVA the best idea, or just say we go for secure way and put in a permanent scaffold to attach the rest of the fresh material to the vessel wall so that nothing else could potentially embolize. So I think this is a point to discuss. Prozent sind verschiedene Größen, bitte bis zu 4. So I already discussed the next step. I won't name it by now, but we can ask into the round, into the group, the delegate, what could be the potential next step?
Would anybody like to write into the chat and I'll put it to Dr. Lichtenberg?
So I think the biggest challenge is now not to embolize. While we made some good progress here with the Phoenix device and this mixed morphology, the next step should definitely secure the whole thing and not potentially embolize somewhere. Ich denke, wir gehen zurück auf den 14er Draht, bitte. So we change the wire back to an hydrophilic coated wire then for the next steps. While we are changing the wire, I can show you an angio without wire in there. I think it gives even more a better view here. So let's summarize. We have a very diseased P3. We have a diseased TP trunk. ATA is not too bad. There's still some minor thing at the origin of the anterior artery. So this is okay. Let's check the outflow and then go from there. Well, we still have a two vessel runoff. Here are no signs of pleural embolization so far. So a proof of concept of an Archimedes screw principle in such a scenario. Yeah, okay. So good inflow from the anterior tip as well as the posterior tip. So I think we are safe with this, but we should keep it safe. And the question is now what to do now. Okay, den 14er bitte ist da. Genau. So let's get a wire back into it. I think I will go back into the perineal first. So let's think what we can do is let's do another IVUS and check what we have left. Is it thrombus adherent to the wall, vessel wall? Is it still some plaque formation? So what did we leave back? And I think we can go from there and then decide what should we do next. IVUS dann als nächstes Jahr läuft man. So let's see if I can manage it into the perineal again. Yep, here we go. Oh, there's even the posterior is also good. As this is the more important vessel. Okay. Yeah, let's do IVUS. So can we go back to IVUS? Yep, thank you. kleinsten und kürzesten Renzern, die wir haben, bitte. Mal gucken, was das ist. Ja. Stand, ne? Geht's hin, die Renzern sind noch nicht hier. Okay, so here we are. Oh, and IVUS always tells you the truth. So, Robert.
We don't see the angio, Michael. So I think you're
Oh, you
distal
see
and
IVUS. You see IVUS.
I see IVUS. Yeah, exactly.
Yeah,
So
that's the point. Yeah.
yeah,
Yeah.
So,
dissections
So,
are
uh,
an order. Yeah,
and here's still in high-grade stenosis
yeah,
here.
yeah. But that sorry, I missed. You mentioned it, but I missed it. It was a 1.8 Phoenix you used.
Yeah, because the idea was to
go
dive
deep
also
into IT. Yeah,
deep into, yeah. Maybe 2.2 would have been also an option here, but then TP or antitip artery would have been issue, so always a compromise.
Yeah.
So here's some kind of dissection you can see here, or whatever, however you call it. So I think we need to secure here this stuff here, especially this stuff.
yeah.
I see nicely. We can go back to Cam and Andrew, please. So we have options now for these scenarios to secure plaque against the vessel wall. I think, first of all, any more debulking would not help here. So therefore, I will do something to secure this plaque. I will not do an POBA right now because with this POBA angioplasty, there's the risk that some stuff could migrate. So therefore, my concept is a little bit different, which I'll show you now in a second, as we have this option now. Okay. So a micro mesh idea is the plan. Yeah, this is a double layer stent I want to implant now. This double layer stent helps to protect this free floating stuff against the vessel wall. So good concept we also know from the carotid interventions. And therefore we have now a Renson stand on it, on the wire. Katharina's bringing it forward. And then I will directly implant this into the P3. And with the micro mesh.
How long is that?
Here, you will see it in a second. It's a 540. So it's from a diameter perspective, it's good. It's long. Its diameter is good. You see it.
Yeah.
So it's a monorail system. Go a little bit back. Schleuse sichern, bitte. So you see the distal, very huge marker. Here I start to open it. And then see a proximal marker. This will go away, but this will show where the landing zone of this Renson stent will be. So. Okay, so length was good, 540. Yeah. Okay. Yeah. So let's take the wire a little bit back again. Okay. You can nicely now see it, and sometimes you can even see the micro mesh in the stent scaffold a little bit. Not so visible here, but this is how it looks like. The question, of course, would come up, why not using a super stent? Yeah, super stent is super for P3, of course, but if you have still some fresh things in there, there's a risk even with the superior stent that something migrates and embolize. So hopefully this concept worked now well here. Oh yeah, okay. So this is secure. Yeah. This P3 segment. Yeah. So now we need to decide what to do with the rest of the story here. Uh-huh.
Yeah.
But I think the idea here of a micro mesh is okay. But this stent is, let me say, very short to the offspring to the antertip artery. So therefore, we need now to decide what to do now. And it's still a bifurcation complexity here. And of course, our goal is to secure both. Yeah? And therefore, we are coming now to the next step. I typically do in these complex bifurcation things. Vierer, Micro, nicht so lang. Noch was dazu? 40er? Yeah, 40 nehmen wir. So what is the next thing I would like to do? I will guide the wire into the antertip artery. Hopefully this is still possible here. We are still very close to the offspring of the artery with the Renson stent. Otherwise I need a catheter to dive in there. Here we go. So, and now we do a kind of bifurcation stenting with a dedicated braided stent, and then we'll go through the stent. We will implant this from the arter into the P3, and then dive through the stent struts into the TP trunk, and then probably finalize this with a drug-eluting stent. So the first step is now to bring this micromedical stent, which is a woven braided 90-node stent, into this antertip artery. So this is a superior stent for BTKs, how I call it. This is this. It looks longer than it is because it's a braided like the superior stent. So it will shorten. So, and this is the tricky thing here. We of course don't want to have too much overlap here. So I push it in, it will go down while I'm deploying it. You see, now it's coming up. I'm pushing it down. So overlap not too much and not too less. Okay, I think we are good here. Yes, so we are good here. So this was a 440. Okay. Okay, so and now the idea is, okay, we are still not post-dilating. Yeah, this is still not the topic right now. We are now diving, Draht kommt nach hinten, diving through the stent struts, hopefully easily, otherwise I need a support catheter, into the TP trunk. So let's first check it where it is. Let's do a roadmap. Wenn wir 2020er Ballon haben, bitte. Here we go. Huh? So we still have patent vessels, no, pushing thrombus in one direction or the other. So we secured the antertip artery. Now it's the challenge to dive through the stent struts, which are very tight, into the profunder. See if that works without a support balloon or catheter. If that doesn't work, Katharina already has a balloon prepared where we can push this wire a little bit. Ja, tut mal drauf, bitte. Ich krieg's auch nicht rein. Here we go. Stop. We made it. Okay, sorry. Sorry. Okay, Warren, Robert, the idea is clear what the plan is?
Yes.
Okay.
I mean, I think some very nice new tools you're showing us. I mean, the question, of course, if you're in a lab that doesn't have these technologies available, and would divert to, well, I mean, they would debulk and then normally would DCB or POBA, right?
Yeah, but then this is a super high risk
Yeah,
of
yeah, for
migration.
embolization.
Yeah,
Yeah.
for embolization. Yeah. Also in 0, 3, 0,
So in that case, would then the only option
18,
be
20.
working with emboli protection filters before doing the
Yeah, but
visualization?
again, the question where to put this filter. Yeah. Do we secure? Yeah, you have to decide between A, B, yeah,
Yeah,
anti-tip,
yeah,
positive, where to secure. And therefore, and maybe I can tell a little bit about the new concept where we are cooperating here. This is a concept of proximal flow inhibition. Yeah.
Mhm.
So on the level of the sheath, we block the artery with a dedicated self-expandable device,
Yeah,
20.
yeah.
And with that, you don't have an antegrade flow. So you can do what you want to do. And then at the
Suck
final step,
out.
you
Yeah,
just aspirate. Yeah.
yeah. Same concept as in the carotids, right? With like the MoMA, the reverse flow
Yeah,
filters.
correct. Yeah,
Yeah.
correct. And this is a
Interesting.
nitinol cage, yeah, which you can open, which adapt to the vessel size. So up to 8 millimeter. This is for above the knee. And there's also BTK device available. So where you can place whatever of 90 centimeter or 50 centimeter sheet in P3 and block there.
Yeah.
Yeah.
Well.
Yeah. It's not approved yet. Uh, of course, it's not approved in Europe, of course. Yeah.
But you have they done clinical cases already with it?
No, not yet.
Ah,
We are still waiting for the approval. Also a nice thing, yeah, in Europe. We have to wait for approval.
that
I
takes
see
longer.
nicely.
Ah, look.
Okay, ja, see what happens here.
Ja.
So, ich brauche einen Ballon. I need a balloon. 2-0, nichts machen. Ich brauche einen 2-0er Ballon. Kurz, frisch. 2-0 kurz. Yeah, this is because of the very tight thing of the. Yeah, so 2-0 haben wir am Tisch. Yeah. Yeah, this could happen here with this tight micro stand here. I think that's still okay. Yeah. We will when once we balloon it, then it's strengthened again. So this is a nice thing here. Yeah. But first, we now need to get through these struts here. So I will balloon it right now. Yeah. So this is a bee farm thing. We are waiting, getting approval for easier studies. Whereas in the US, they already did clinical cases based on 510K. Yeah.
Yeah. Well, that was expected with the new regulations, right? That we would lose that competitive advantage in getting device to market quickly.
Unfortunately, yes, I agree. This is the case. Yeah. So 2 O balloon very easily went through this here. So could of course be that yeah, these tight struts come back again. So let's see if in the next step we are able to get this then through this strut. Auch dann nachher bitte einen Vierer Ballon, kann von mir aus ein 18er sein, in 60. Okay. Wir versuchen den Drug-Eluting Stand nochmal. Yeah, therefore, as you just mentioned, just ballooning and DCBing it, we did this in the past and we saw really not nice outcomes in terms of pleural embolization with this soft material. So therefore, our approach is to use kind of debulking device like the Phoenix here, which I think did a nice job. So now we made it.
Nice.
Yeah. Okay. I think the cardiologists name it a provisional T stenting.
Mm-hmm.
So this is how they treat the LAD and the B1, D1 bifurcation. Okay. So I'll take this monorail out and then I go back into the undertip. I think we can take the wire also back already. Okay. Mm-hmm. Awesome. Now let's go back into the, yeah, now of course it goes easy into the TP trunk, but I think we should make it here into the undertip and then we balloon this. Nice. So vierer Ballon drauf bitte. Now we do a long 4 mm balloon angioplasty and get the whole stuff ballooned. And while I'm doing this, I will pull a little bit on this balloon just to straighten here a little bit this micromedicus stand, which I made a little bit look ugly here. Kurz halten bitte. So like this. Okay. Yeah, now it's straightened again, you see? Yeah. This is how you can easily reshape such a braided stand. Huh? Oh, okay. Was. Okay, now let's see if this plan turns out to be good.
Mm-hmm.
Oh,
That's new, huh?
it's at least a little bit better than before.
That's an understatement.
Yeah, no, but the important thing is, did we embolize? This is the question, which I don't hope. This is okay.
Yeah. Stronger flow in perineal as well.
Absolutely, yeah. Yeah, I think the flow is good, huh?
Yeah.
Yeah, so let's do a final IVUS just to check if we have a good wall up position of everything here, not free floating stand struts. Also very important aspect, yeah, in these scenarios. And I think then we are done with this. So, yeah, my definitely suggestion for these case scenarios is we need to stop TOBA in these scenarios. Yeah, this is probably not helpful. It's important to do some kind of debulking here, not to lose any vessels and then end up with 24 hours of thrombolysis with all potential complications. So I definitely advocate here for thrombectomy, atherothrombectomy, atherectomy in these scenarios, and the Phoenix worked well here. The Phoenix is definitely not a thrombectomy device, yeah, for sure, absolutely not. but based on IVUS, we could see that there is a clear organization of this material. So this was the decision process why we used the Phoenix here in this scenario. So we are coming now close to here, this stand area. So 5 was definitely not an understatement here based on the size of this vessel. Well, 6 could have been even an option. So we are coming now. You see here pushing this rest material. This is nice to see here. See between 12 and 3 o'clock. Yeah. See how the first of all, it's a nice shaping of the stand structure. But on the other hand, it pushes all the material against the media intima. Between 12 and 3 o'clock. Can we go live again, Kimberly? Yeah, thank you. No, sorry, this was not for Italy. Sorry, go back to IVUS. Yeah, thank you. Sorry, this was clear miscommunication. So this is the micro stand. Yeah, this is the micro stand. This is in between a short stand strut, not an overlap situation, but I think that's okay. And here's the micro stand. You see a different, echogenic morphology here.
Great.
Yeah.
You see the tight stand struts here. It looks even like a closed cell stand. And now we are in the antetip artery. This is the normal.
Good. That's good.
Yeah. Okay, so let's do a final angio just to see that everything is still stable. And I think I have to say it, sorry, we are already done then with this case. Oh, but it's still okay. Let's just take the antitip a little bit out of the bone just to see if there's no issue in the antitip distal to the stand. I missed a little bit. I think that is better. No, but this is okay. No. Yeah. Sorry, what should I say? I think we are done.
Very nice.
Yes.
Very nice. Yes.
So comment to say amazing from the participants. Is there any other comments, please?
Yeah, if there are any questions, please forward it. If this is not the case,
It's an interesting case that you have that well, not isolated, but that's stenosis from the P3 down into the trunk. But I mean, it doesn't seem like distally there's a lot of calcification. Also, the inflow vessels were pretty good. So it's a very localized disease. Is that common or rather uncommon?
No. This is a very strange thing. You know, this patient came yesterday, and I actually had a different patient schedule for this morning. But when we saw this ultrasound P3, this duplex, I said, this is super interesting because this is not so typical. And this is a very good example how we can, with modern technology, especially with such debulking technology, get good outcomes without embolization complication. This was the intention. So it's really not a typical thing here. So it must be a plaque rupture, maybe a plaque rupture with thrombus on it. Maybe this is the pathology here. I don't think it's a P3 embolism from the heart. I don't think so, because we did not see any areas where embolus was seen. So I think it's a plaque rupture based on the stenosis.
That's a great result. Thanks.
Yeah, absolutely brilliant. Thank you.
Thank you very much again for your support, and it was a pleasure to host you here this morning. Hope to see you soon.
All right. Thanks very much, Dr. Lichtenberg, and thanks again to you and your team. And please look out for the next event, which will be in September, another live from session, and we will share the links on social media in due course. So thanks again.
Thank you. Thank you.